Thank you all for joining today. Let me introduce Dr. Anup Katyal, who graduated from India in 1990 from medical school. Incidentally, Anup and I graduated in 1992. So I think we're the same batch. I thought you're looking a lot younger, so I thought you're a lot junior, but I think we graduated at the same time. He did his training in internal medicine. He's a critical care specialist with specialties in sleep medicine and neurocritical care. And he's been a frontline worker since the COVID pandemic. And he's been a great help along with Prasad Garmala, Kushbu, and then there are a lot of other critical care specialists in our eGlobal platform, educating us over the last 3 months in our doctors launch in eGlobal. Thank you, Anup, for all they do. And he's also had interviews and publications in Washington Post with his experience as a critical care specialist, as well as at eGlobalDoctors. So appreciate all your time for eGlobalDoctors and giving all the care to the counseling for eGlobal patients, and as well as on your regular job in St. Louis. Without further ado, Dr. Anup Katyal, critical care specialist, is going to educate us about the Delta variant and the vaccination and what is going on right now in the US. Thank you, Anup.
Thank you, Dr. Srini, for those words, and Krish. I'll try and share my screen. Can you see it?
We can see it. Yeah, perfect.
Okay. So, when Dr. Srini and Krish asked me to speak about it, I said, I'll briefly mention what I've been seeing here. And obviously, if you start talking about COVID, each of them becomes like a big topic. So I've tried to summarize a little bit. So brief, overview, coronavirus, if you see, even before COVID hit us, there were other coronaviruses that we would see in the hospital, but never caught our attention because they were mild, like flu-like symptoms. But it's like alpha, beta, gamma, and delta. And if you look at coronavirus, I said alpha and beta, SARS-CoV-2 in 2002, Middle Eastern Respiratory Syndrome in 12, and now COVID-19 in 2019. The conventional thought processes, at least, for the first two, originated in the bat, and certainly COVID-19 originated from bat. There's an intermediate host, which for SARS-CoV-1 was a cat, civet cat, for MERS, camel, and for SARS-CoV-2, we are not sure, and then it gets transmitted to human. It's interesting, of all the viruses, there are only three, NL63, SARS-CoV-1, and SARS-CoV-2, that require ACE2 to gain entry into the human body. So we've seen this all along, that, when we think of COVID-19, we talk of asymptomatic, mild stage, moderate stage, severe illness, and critical illness. And it goes without saying, the first 5 to 7 days is the viral replication, and then we get into the inflammatory cascade. And so early on, antivirals may have a role, and then subsequently, all our efforts are directed towards decreasing the inflammation. So I'm just going back, like Dr. Srini mentioned, that we've been dealing with this for over a year. And just to tell you how medicine evolves. So what is true today may not be true 6 months from now. I remember March, April 2020 in the ICU. What we were told was, do not use steroids, because we have data from influenza, we have data from SARS-CoV-1 that steroids impede viral shedding and can prolong the illness. If someone was on 6 liters, we were asked, intubate these patients. ICU patients who were there day 14, day 20, we were giving convalescent plasma. And this was the most controversial thing, that they said, if someone has COVID and is in the ICU, you should start full dose anticoagulation. This is prophylactic. And some group even went to the extent that saying that, there's so much of thrombosis because of SARS-CoV-2 infection, we should give thrombolytics to these patients. So just a few slides. What do we know about convalescent plasma a year down the line? You can look at all these randomized controlled trials. One of them even occurred in India, and you can see the forest plot on the right. There is no advantage to using convalescent plasma, whether it is outpatient setting or inpatient setting, except for one study out of Argentina looking at people age above 75 when you use convalescent plasma within 72 hours. We don't see that kind of a population. So the conventional wisdom right now is convalescent plasma has no role. Then talking about steroids, this was a meta-analysis published in JAMA. And what we know of few things that can decrease mortality in SARS-CoV-2 or COVID-19, one is steroids. So they play a very important role. And you can see this forest plot suggesting favoring steroids versus favoring not steroids based on all the trials that have been done, that it is certainly, favors use of steroids. And using steroids definitely, helps reduce mortality from 41 to 32.7%, looking at all these studies that have been done. Now, what about use of IL-6 inhibitors? So this was recently published in JAMA from WHO, looking at 27 studies using IL-6 inhibitors. And early on, when we were talking about tocilizumab, what we found was it was not beneficial. But what we have found now, 1 year down the line, it is a very effective drug to use in the right setting with steroids. The most important thing to note is the timing. You have to use it early. The moment someone transitions from nasal cannula to OptiFlow or non-invasive, that's the time to use tocilizumab. We can talk about studies, the REMAP-CAP and recovery trial published recently, which showed, mortality benefit from using IL-6 inhibitors. Again, the take-home message is, in the appropriate patient, use it early. If someone gets into the ICU, gets on pressors, that's an indication to use IL-6 inhibitors. Obviously, none of these drugs are, without side effects, so you have to have the exclusion criteria. You don't suspect a secondary bacterial infection. You don't have LFTs that are abnormal. You don't have, significant thrombocytopenia or history of, GI perforation. So that would be the perfect candidate. And time is of crucial importance today, but I had several case reports of what I had seen in the ICU, where they were successfully managed by just, diligent use of steroids, IL-6 inhibitors. One thing I would mention about steroids is one size does not fit all. Though the recovery trial told us 6 milligrams of dexamethasone, you cannot use the same 6 milligrams for someone whose BMI is 25 and the same 6 milligram for someone whose BMI is 55. So use your clinical judgment and use a higher dose in those settings. So one of the most controversial things that we've discussed ad nauseum at eGlobal also is, what are the recommendations for VTE prophylaxis? And different societies have come up with those recommendations. American College of Chest Physicians says if someone is critically ill, use prophylactic dose. In non-critically ill, prophylactic dose, low molecular weight. The reason low molecular weight heparin is chosen over heparin is you don't have frequent trips to give, 3 times these heparin shots. After discharge, extended prophylaxis is not recommended and non-hospitalized not recommended. Whereas International Society on Thrombosis and Hemostasis says, prophylactic dose, low molecular weight or half therapeutic dose may be considered. Non-critical prophylactic dose after discharge on a case-by-case basis, they say you may consider low molecular weight heparin or DOACs for up to 30 days. And non-hospitalized, there is consensus. Now, this was based all on, not randomized controlled trials, but retrospective studies. So fast forward now, we have data from ATTACC, ACTIV-4a and REMAP-CAP multi-platform randomized controlled trials. So this is all preprint. We are anxiously waiting for the final, publication. And what they looked at, it is very interesting. If you look at the top, primary outcome was organ support-free days. And if patients had COVID-19, this is moderate COVID. They are not requiring ICU. Use of therapeutic anticoagulation, that is full dose anticoagulation as prophylaxis, was much better than prophylactic dose. However, in the ICU, full dose anticoagulation caused more bleeding and increased mortality. So the conclusion of this is interim analysis from, and this is, multi-country randomized trial looking at prophylactic versus therapeutic dose. What the conclusion is, if you have moderate COVID, you're admitted to the floor, you will benefit from full dose anticoagulation. If you're sick enough to be in the ICU, you will benefit from prophylactic dose anticoagulation. So this is totally opposite of what we did early on. So just discussing this update that occurred just 2 weeks ago from National Institutes of Health, which keeps updating. And they recommend that, for outpatient setting, not hospitalized patients, depending upon, their risk factors, age, etc., we have only 2 monoclonal antibodies that are listed above. This above one is the Regeneron one. The Lilly one has been withdrawn because it was found not to be effective. And then it goes down. If someone is discharged from the hospital in stable condition, you don't want to continue remdesivir or steroids. But if you're discharged and you require supplemental oxygen, there is insufficient evidence. But if you're in the ED and you are discharged, then it says you could use dexamethasone. As far as inpatient management is concerned, this is what we follow. Hospitalized but not requiring supplemental oxygen, no role of steroids. If you require supplemental oxygen, remdesivir has a role plus steroids. Hospital and requires, oxygen delivery through high flow or non-invasive. This is where a sea change has occurred. Yes, you'll use steroids, role of remdesivir if we are within 10 days of hospital admission versus, within 10 days of onset of symptoms versus greater than 10 days, there's a benefit of using remdesivir. But use of IL-6 inhibitors and Janus kinase inhibitor, either or in conjunction with steroids, help reduce mortality. And if you're hospitalized and require, mechanical ventilation or ECMO, then obviously dexamethasone and then role of tocilizumab, which we discussed. So July 2021, how do we practice, treating patients with COVID? We avoid early intubation. Steroids have a role 2 weeks onwards if they require supplemental oxygen. No role for convalescent plasma. And in ICU patients, initiate prophylactic anticoagulation. When I see a patient in the ICU who has COVID, I ask 4 questions every day. Is this just normal progression of COVID? You have things like CRP to go by. Is there a secondary infection? You have cultures, you have, procalcitonin to go by. Is the heart involved? So don't forget, COVID-19 is not exclusively a disease of the lungs. It can involve the heart, GI tract, brain, and every organ system. So does the patient have myocarditis? Is that playing a role? And last but not the least, I always look at the D dimer, not in isolation, but if it is rising, I do venous Dopplers. It's difficult to do CTAs on these patients. And if they have VTE, then I put them on full dose anticoagulation. Otherwise, I will continue prophylactic anticoagulation. So the take-home message for step-down units or ICUs is remdesivir may have a role. Steroids definitely, individualized strength CRP, tocilizumab, baricitinib, use early in conjunction with steroids, and VTE in ICU empiric therapeutic anticoagulation not advisable. Screen patients for VTE, trend D dimer. So conclusion of current treatment is what one does early on in TCU, ICU in the management of COVID-19 determines outcome. What one does later on in the course of hospitalization determines length of stay. Now, talking about vaccines, they have been in the news. And what we are currently seeing is, adenovirus or vector-based vaccine. And to quote what we are using currently in India, the Oxford AstraZeneca, the Covishield is this adenovirus vector vaccine. We have a similar vaccine that is produced by Johnson & Johnson that is available as a single shot vaccine in United States. So the difference is the Covishield in India is a 2-dose vaccine. In America, it's a single dose vaccine. Then talking about inactivated vaccine, this is the one which is the Covaxin, which is produced indigenously in India by Bharat Biotech. That is available only in India. It has pending approval from WHO. The third vaccine that we are most familiar with is the mRNA vaccine. And we have 2 of those, the Pfizer-BioNTech vaccine and the Moderna vaccine. And then we have the plasmid DNA-based vaccine that is being developed in India. And then you have something that you all must have heard and read in the news, is the Novavax. That's a nanoparticle recombinant vaccine that is also preliminary data suggests to be quite effective. So what has happened is when we get infection with COVID-19, a typical person, the virus multiplies and you have 1 billion copies made. And you can imagine some of these copies are just carbon copy of the original, but some have certain mutations. So it's but natural. We know from influenza that viruses mutate all the time. So WHO has classified these as alpha, beta, gamma, and delta. Alpha is the one that was in the UK that became the predominant virus, but now the what you call Delta virus that originated in India in December 2020 has become the predominant virus. More than 90% of the infections in UK and 83% of new infections in United States are the Delta variant. Delta variant. There is a beta variant that was first noticed in South Africa and the gamma in Brazil. And if you look at what we know about the current status of these vaccines, you can see against the alpha variant, the mRNA-based vaccines are effective. The adenovirus-based vaccine, which would be the Johnson & Johnson vaccine and the Covishield that is available in India and mostly in Europe, you saw the efficacy decrease. And that is true across for beta and gamma. And as you can see for delta, it's question mark. We have more data in the last several weeks about the vaccination efficacy against Delta variant. One thing I will point out is that the Pfizer BioNTech vaccine, Moderna vaccine were the first to be approved. At that time, we did not have efficacy against the variants which subsequently came up. So when the Johnson & Johnson vaccine, a single dose vaccine was approved, that was the vaccine that was found that 49 days after receiving it, not a single person who had the beta variant, because it was tested in South Africa, ended up being in the hospital. So you have to tease out what do these vaccines do, whether they cause an infection or whether hospitalization. So that becomes a very important issue. So this is the Delta variant. As I mentioned, this is the B1617 and there is B1617.2, and there are mutations that occur in the spike protein. So from the original wild type virus, there are 12 mutations that have occurred in the spike protein to produce this Delta variant. So why do we worry about Delta variant? Delta variant is 60% to 120% more transmissible than the Alpha variant. We talk about something called as a reproductive number. Reproductive number for the original wild type coronavirus was 2 to 2.5. For Delta variant, it is 3.5 to 4. Means that if one person gets the infection, how many more people can that person infect? So for the original SARS-CoV-2, the wild type virus, one could cause 2 to 2.5 others to be infected. With the Delta variant, it can be as many as 4 people that can lead to infection. There is 2 times increased risk for hospitalization. There is ongoing debate that yes, it is more transmissible, increased risk for hospitalization, but is it more, apt or more likely to cause someone to die? That question has not yet been answered because we see more and more admissions. It leads to more and more deaths, certainly, but that question we don't know the answer to. Recent studies have found that this is coming from China. When they looked at the viral load, the Delta variant carried like 1,000 times a higher viral load who were symptomatic. And the difference that we are seeing is, if you look at the slide below, on the left, the timing, infection to RT-PCR being positive, while it took 5 to 8 days for the original SARS-CoV-2 to get positive, you can see it getting positive even earlier, just reflective of the high viral load. And that the day the testing turned to be positive, you can see the detection threshold with the Delta variant, it is, 1,000 times more copies are found, and that leads to higher transmissibility. So there was a lot of commotion recently when Israel released some data because Israel has done a very good job about with immunizing its population against the Pfizer-BioNTech vaccine. And what they found was that recent data suggested that after the 2 doses, 2 weeks after that, it was only about 64% effective in preventing infection and symptomatic illness. At the same time, it found that it was over 90% effective in preventing hospitalization. Now, data from June to July that was just reported yesterday shows that there's a further decline in preventing infection from 64% to 39%, but 91% protection against hospitalization. So again, as I said, though it is maybe not as effective in preventing infection and symptomatic illness, but it is very effective in preventing hospitalization. And that is what our focus should be with regards to this variant. So there's a lot of debate, once you get the infection, whether it is, naturally or through you are immunized against COVID-19 through vaccinations, what is the duration of immunity? So this was a study published from Washington University here in St. Louis, where they looked at 77 patients and did bone marrow biopsies on 18 patients 7 months down the line and 11 months. And what they found was bone marrow plasma cells, which, help the body to produce the antibodies to fight infection, they were lying dormant in the bone marrows, though the neutralizing antibody titer had waned, suggesting that just relying on neutralizing antibody levels may not be the right way, and people do develop robust immunity against, this COVID even after natural infection. Similarly, there is data out of UK looking at Covishield vaccine and, producing long-lasting immunity. That's the theory that is being postulated. So we don't know a lot about this as of now. Now, what do we know about effectiveness of COVID-19 vaccines against the Delta variant? So this was just published 2 days ago in New England Journal. This was a study coming out of United Kingdom, and it's a big study. They looked at 20,000 patients, and I would like you to concentrate on this underlying, red lines. So if you look at the Pfizer vaccine, after first dose was about 36% effective, and after the second dose was 88% effective in preventing infection, that is symptomatic infection. And if you look at the Covishield vaccine, the first dose 30% effective, and dose second 67% effective. So this is what we know as far as efficacy of the vaccines. And this is just a reflection. You can see after dose 1, the Pfizer vaccine compared alpha variant in blue and delta variant in purple. It is not as efficacious, but after the second dose, you can see. So it is very, very important for people to get the 2 doses of vaccine, and this kind of protection you get is 2 weeks after the second dose. So this speaks about, what we know regarding the Covishield and the mRNA vaccine. And one other thing is, in UK, they have their own sort of protocol where the 2 doses are not given 3 weeks apart like we do here in United States. So this is just a reflection of interval from 1 to the second dose regarding use of the both, the Covishield vaccine as well as the Pfizer-BioNTech vaccine. You can see it was spaced as far away as, 103 days, but the norm there in United Kingdom is to give the second dose like 12 weeks after the first dose. So what about the Johnson & Johnson vaccine that is available here in United States? So we have some data, in vitro data suggesting, you can see B1617, that Johnson & Johnson vaccine is effective in producing neutralizing antibody, but this is in vitro data. Now, we do have data on 20 patients that was just published in New England Journal on July 14th, suggesting that Johnson & Johnson vaccine does produce effective antibody response against the Delta variant at par with what we expected from, the Covishield vaccine, since they are similar adenovirus-based vaccines. So one question that is frequently asked is vaccination safe in pregnant women? So this was again published in New England Journal, June 17th, looking at preliminary findings of mRNA COVID-19 vaccine safety in pregnant persons. And you can see this is 133,000 patients who voluntarily disclosed their information about the side effects after getting the Pfizer or BioNTech vaccine. And you can see between pregnant and non-pregnant, there was slight increase, incidence of pain. That was the main difference. Otherwise, there were no serious side effects reported from mRNA vaccines in pregnant females. So what do we know today regarding vaccines? Known that vaccines do work, known unknown duration of protection, and unknown. Will we need a booster dose? Again, there are some countries that are doing it. And what about mix and match? Here in United States, we don't mix and match. In Canada and Germany, they do allow so. Thailand is the third country that allows you to get one adenovirus vaccine followed by a second mRNA vaccine. The WHO has warned that we should not mix and match. There are studies ongoing. And again, you cannot, come to judgment just based on 200, 300 patients. We need large studies to come to some definitive conclusion. This is all I had. Thank you. And I'll be happy to answer any questions anyone has.
Thank you, Anup, for that wonderful presentation. That was, I think, it's very enlightening. I think I learned a lot from the Delta variants. I'll start with one question. So if somebody had an infection already with about 3 months ago or 6 months ago, with the Delta variant now in the United States, I'm talking about with vaccination or without vaccination, is it going to increase dramatically the risk of having a new infection, or is it the same with the antibodies and the vaccination-related antibodies? The risk is pretty reasonable.
The risk is low. We have data from 160 million US population that has been vaccinated. And what we know is 5,500 patients have had hospitalizations and deaths. So that's a very small percentage. So for the most part, people will be protected. There will be breakthrough infections. No, what you call, vaccine is foolproof, like people say. And it is appropriate to say currently what we are seeing is basically a pandemic of the unvaccinated people. So to answer your question, you will see breakthrough infections. And again, what is the current recommendation? Should you be, testing these people who are vaccinated? We know how, sensitive RT-PCR is. You have a single virus. It does not distinguish between live virus and dead particles. So we may be also picking up patients who are just, as we call, colonizers, but not be transmitting the virus. And so we are seeing those, but majority of the patients who will get the infection would be with the Delta variant would be the unvaccinated people.
Thank you. Gopi, I'm on the phone, so I can't see. If anybody has questions, please raise their hand so that Gopi, if you can give them the chance to just one by one so that you can ask the questions.
Yeah. Thank you, Dr. Anup Katyal. This was amazingly done. At least I'm so impressed with the kind of details which you went through with the slide decks. So thank you for sharing your knowledge, which is very, very informative. So let me ask the audience, is there anyone who would like to ask any questions to Dr. Anup regarding Delta variant?
Can you hear me? This is Dr. Vittal.
Can
you hear me?
Yes, we can. Go ahead.
Dr. Anup, that was a good presentation. With the natural immunity after somebody gets COVID infection, how long the natural immunity lasts, Dr. Anup?
So this is the one that I quoted you, the study out of Washington University, which currently people thought, that after 9 months, the immunity may wane. But like I mentioned in the study of 77 odd patients, where they not only looked at the neutralizing antibody titer 7 months and 11 months after exposure to SARS-CoV-2, they found in a majority of these people, in fact, overwhelming, the bone marrow had these cells, the plasma cells that, help fight the virus to be very, very active. So suggesting that we don't know the answer yet, but the thought that, like for influenza, etc., will this be lifelong? We don't know. Will it be 2 years? We don't know. But certainly We don't know the right answer, but it is not just 3 months, it is much longer than that after natural infection.
So the current recommendation is, as far as I know, they should get vaccinated within 2-3 months of COVID infection, right?
So that is based on the fact that you develop certain neutralizing antibody after natural infection and after vaccination. But the response you get after a natural infection, you can, take it as it is good enough. But by getting vaccinated, you act like a booster to the immune response your body is producing. So it is a much more robust response than you get after natural infection. So that's the thought process behind asking people who've had a natural infection to get vaccinated.
And what the latest is still trials going on? Children 2 years and above, 2 to 12, any latest?
So we know we have data here, at least in the United States, for 12 to 16 who are now Pfizer vaccine has the EUA. So there are ongoing studies looking at 9 to 12, 6 to 9, and then 2 to 6. And what I understand is the results will not be available till end of the year. Previously, they thought that by Thanksgiving that they'll have enough data to start vaccinating children between 2 and 12. But what I understand is final results may not be out till end of the year.
Thank you.
Dr. Anup, this is Krish here. I have a small question.
Sure.
This question came last week from my son, who is an 8-year-old kid, Arjun. So he asked me these questions, right? Now we are talking about COVID is going on since last 1 year now. Kids are so fed up. We went from, like you said, alpha, beta, gamma, and now going into delta. So are we expecting any kind of a single vaccination for the lifelong as such, no matter what it comes in future, whatever viruses we are expecting due to mutations?
So this would be something I would think on the lines of influenza, that we know viruses mutate, and as we all know that it's not the same influenza virus we get vaccine every year. I know the efficacy sometimes is very low. So based on what the prevalent strain may be, that's where the boosters will come into play. And not to put a damper to your son's alpha, beta, gamma, delta, there's also a lambda that is a virus variant of concern that WHO has labeled, that was first reported from Peru. And so we have those lambda variants also, seen in the United States, but luckily it's not as virulent as the delta variant, and both mRNA vaccines are highly effective against lambda. So to answer the question, the thing is, till everyone is vaccinated in the world, no one is safe. So this delta variant originated from India. That's what conventional wisdom is. So if you have large swaths of population in the world, whether it's Africa, whether it is Europe, whether it is Asia, not vaccinated, just to say that, because viruses will, transmit, viruses will mutate, and depending upon the mutations, we will have to tailor the vaccines according to the mutations. So it is hard to predict that there will be one vaccine that would be, effective against all the variants. And certainly there would be variants beyond what we know now.
Thank you, Dr. Anup.